Hi, good evening. So this week we'll be continuing our lecture on antihistamines, and this week we'll be discussing the second generation antihistamines. Last week we did a detailed video lecture on first generation antihistamines. So I request you that before you see this video, it's better to go back and see the part 1, the first generation antihistamine. In that video we discussed what is histamine, how does it act, and how are we able to inverse agonize, or let's say have a kind of a negative action by utilizing the histamine receptor, and the generation of first generation antihistamines. So in that video we talked about that we have four different types of histamine receptors: H1, H2, 3 and 4, and out of that H1 is the receptor of our interest. Through the H1 receptor, the histamine acts on various tissues, predominantly blood vessels and all the inflammatory cells, and that is the major mechanism through which you have all kind of allergic reactions, as long as histamine is the mediator of that. Remember that the mediation of itch is a very complex and a complicated scenario and a very complicated process, and histamine is not the only mediator of itch. Okay, there are other mediators. Maybe in the future we can make a detailed video on what is the pathomechanism or the pathophysiology of itching. Okay, so but on in continuation of that video, this week we'll be discussing the second generation antihistamine. Okay, so second generation antihistamine will still act on H1 receptor. Do not get confused between H2 antihistamines and second generation antihistamine. H2 antihistamine will act on the H2 histamine receptor, which is predominantly located on the gastric mucosa, and it is responsible for the secretion of gastric acid. Okay, second generation antihistamine are the antihistamines which will act on H1 receptor, which is predominantly responsible for your urticaria and itching reactions. Okay, they are known as second generation because after the advent of first generation antihistamines, which include antihistamines like hydroxyzine or chlorpheniramine, subsequent modification happened to the side chains and imidazole ring, forming the second generation antihistamine. Okay, and these modifications were there to forego or to remove out the sedative effects of first generation antihistamine. So in the last video we discussed that first generation antihistamine have a very you could say not appreciable side effect, a very difficult side effect to have, which is somnolence or sleepiness or sedation. So second generation antihistamines were created to get rid of that side effect. And this week we'll be discussing all of the second generation antihistamines in details. So without further much ado, we'll start the second generation antihistamines in dermatology. So second generation antihistamines are inverse agonists on histamine receptors. So just to recapitulate what we discussed in the first part, that we have a histamine receptor here. Let's say this is the cell membrane and we have a histamine receptor. Just to remind you that it's a G protein coupled receptor, or the G type receptor. And inverse agonist means that if histamine attaches itself to the histamine receptor, it will lead to its normal effects that we have. Okay, but the inverse agonist will attach to a different site of the same receptor and will lead to negative effects. Negative effects means that the effect opposite to what histamine would have created. Okay, so that's how they act as inverse agonist to histamine. It's a slightly complicated mechanism. There are multiple receptors which are constitutively active, and the histamine and or antihistamines block the action of histamine receptor, and thus leads to the negative effects or the effects which are opposite in direction to the normal working of the receptor under the action of histamine. Okay, so these are the inverse agonists. That means the effect will be opposite to that of histamine. Second generation antihistamine have a high therapeutic index. So what is therapeutic index? We have a therapeutic window. The therapeutic window, the lower level of therapeutic window is the level which is minimum dose required or minimum level of drug required to cause the effect, the desired effect. Okay, and the highest is the dose where side effects start to appear. Okay, so the difference between these two levels is known as therapeutic window. That means within these two doses, we can use the drug very safely with minimal side effects. Of course, by the definition of side effects, you are going to have some effects which are not desirable, but they are somewhat okay as long as as long as antihistamine is showing its normal therapeutic effect. So that is known as therapeutic index, the difference between the dose which will cause the clinical effect and the dose which will cause toxicity. So that is the therapeutic window. So second generation antihistamines have a very high therapeutic index. That means a big window. They are poorly lipophilic. That means they are very poorly lipid soluble, and because of that, they do not readily cross the blood-brain barrier. Okay. Remember in H1 antihistamine, they were very easy to cross the blood-brain barrier, and inside the brain you have receptors. You have inside the brain you have histamine receptors, and when this first generation antihistamine cross the blood-brain barrier and attach themselves to histamine receptors, what histamine normally does is to maintain alertness. And when antihistamine block this central nervous system action of histamine, it leads to sedation or sleepiness. So this was a side effect which was very troublesome for the patient. So second generation antihistamines were manufactured to get rid of these side effects. And how do they do it? They are very poorly lipophilic. They are not that much lipid soluble, so they're not able to easily cross the blood-brain barrier. They are highly selective at the H1 receptor and do not bind significantly to cholinergic or muscarinic receptors. Okay, now remember that in the first video we talked about that at the end of nerves, we have a lot of vesicles which has stored acetylcholine and other neurotransmitters. These presynaptic area are also rich in H3 receptors. And many of the first generation antihistamines were having some sort of or some action on other histamine receptors also. So they are predominantly H1, but other receptors like H2, H3 and H4, they were showing some activity to other receptors also. So when H1 antihistamine attaches itself to a H3 receptor, it will lead to or increase, the vesicles containing acetylcholine will be released. And this was responsible for the cholinergic action of antihistamine first generation. Okay, and this led to tremors, dry mouth, and all sorts of cholinergic side effects. What happens in second generation antihistamines are that they are very selective for the H1 receptor. Okay, they're very selective for the H1 receptor and they will not attach themselves to H3 receptor. So these kind of cholinergic side effects which we saw in the first generation antihistamines is very limited in second generation antihistamines. Okay, so let's move forward. Now just to recapitulate that we have four different types of histamine receptors, and we should concern ourselves only with the H1 receptor which is present on smooth muscles, endothelium and brain. Okay, and since second generation antihistamines cannot cross the blood brain barrier, the brain histamine receptor is not that important when you're using second generation antihistamines. Okay, so majorly smooth muscle and endothelium. Smooth muscle is responsible for vasodilation, so under the action of histamine it leads to dilation of vessels leading to redness, warmth and all that. Endothelium is responsible for permeability. So under the action of histamine, the vessels become very permeable and leading to swelling and exudation of the plasma through the blood vessels. And when you use antihistamine, both of these effects are negated, and that is why H1 antihistamines are used in clinical practice. And second generation antihistamine will not act on the brain receptors, and there will be little or no sedation. The H2 receptors are seen on gastric mucosa, and the main action of that is to increase gastric acid. So you have ranitidine, famotidine, cimetidine, those antihistamine which works on acid secretion also. Okay, this slide I've also taken from the first part. You have three generations: the first generation, second generation, and third generation. And many of the times, the second and third generation are clubbed together as second generation H1 antihistamine. So in this video, we will focus more on antihistamines like cetirizine, levocetirizine, Fexofenadine, Loratadine, Desloratadine, Bilastine. So these are the second generation antihistamine which we use a lot in our clinical practice. So we'll be discussing in detail each and every second generation antihistamine so that we will know more about their usage. Starting with cetirizine. So first antihistamine, second generation that we'll discuss is cetirizine. So remember the spelling. For many years, I used to believe that it is cetirizine, but it is cetirizine. Okay. So cetirizine is selectively acting water-soluble molecule. It comes in the formulation of 5 milligram tablets or 10 milligram tablets and also 5 milligram per 5 ml syrup. This becomes important when you're treating pediatric patients. So it's a carboxylic acid derivative of hydroxyzine. Hydroxyzine being the first generation antihistamine. Okay, first generation antihistamine, and it's a carboxylic acid derivative of hydroxyzine. And in the body, cetirizine is converted to levocetirizine, and levocetirizine is the active metabolite. Levocetirizine is the active metabolite. Okay. It has negligible anticholinergic, anti-serotonergic activity. Remember in the first video, we talked about some serotonin-like activity of histamine. So H1 antihistamine have some anti-serotonergic activity, but second generation antihistamine have minimal anti-serotonergic activity. Like all second generation antihistamine, there is rapid gastrointestinal absorption. That means on oral intake, it is rapidly absorbed and maximum concentrations reach within 1 hour. Food delays absorption, but it is not clinically significant. So what do we mean by that? That means it's better to take antihistamines or cetirizine on an empty stomach. It will lead to better absorption and bioavailability. But even if you take it with food, the clinical effect is not that much decreased. So instead, so you can tell your patients that it doesn't matter. You don't have to relate it with food intake. You can take it as much. You can take it empty stomach or with food, but just remember to take it timely. Okay, we just require a proper blood level, and you do not require to club it with any meals. 70% is excreted in urine and 10% feces. So when you are treating older patients or patients who are receiving dialysis or there is any kind of kidney dysfunction, it's better to decrease the dose so that the we can take into account the less excretion which is happening in these kind of patients. So when you are dealing with people of, let's say, prurigo simplex, or maybe any other itching, atopic dermatitis, adult onset, in which you are treating old patients, or you have, let's say, a patient on dialysis, bed-bound patient who has scabies. So you would like to treat with antihistamines, but in those patients where you are suspecting kidney damage, renal damage, or even proven cases of renal damage, you have to adjust the dose. It's better to start with a lower dose because the amount of side effects would be much more, since the major excretion is through urine in cetirizine. Okay. The half-life is roughly about 8.3 hours. Peak levels are reached in half to 1.5 hours. Bioavailability around 70%. 50% of the patient will have good clinical effect 20 minutes after intake of cetirizine, and 95% of patients will have in 1 hour. So this is a good question. Many times our patients will ask that if I have a urticarial reaction and I take a medication, how much time should I expect to get better? So you could say that roughly in about 1 hour, you should have significant response and significant control of itching. The activity persists minimum 24 hours. That means once a day dose is enough. Okay. Although there are multiple occasions where you would like to divide the doses or give multiple doses over the day, but one dose is enough to have its levels for 24 hours. We just have to titrate it depending on how much response it is. For example, let's say this is the graph of drug concentration. This is concentration with time. Okay, and this is the time of intake of cetirizine. So there will be increase, and then it will reach a plateau, and then it will start to decrease. Okay, because of excretion. This time is roughly 24 hours. But let's say the patient will have clinical response only when the concentration reaches here. So for example, patient will only have 50% improvement, but 50% improvement will last for 24 hours. So in that case, you might consider giving higher doses, but remember with higher doses, you will have higher side effects. So it's better to divide the doses, and you can easily go for 5 milligram twice a day dose or thrice a day dose, depending on the clinical efficacy. So it is one of those antihistamines second generation which is considered safe when used in patients of more than 6 months of age. So cetirizine is the safest antihistamine because the age of usage starts from 6 months. Okay. It is also found to inhibit eosinophil migration, and a good amount of usage is seen in eosinophilic fasciitis, in which you have eosinophil migration, or let's say in disorders like insect bite hypersensitivity. So cetirizine would be much more helpful drug. Okay, so it has also been shown to have eosinophil inhibition of eosinophil migration. So this is the structure of cetirizine. We can see that the major this is the modification of hydroxyzine molecule and the modification of side chain coupled with hydrochloride molecules. So that's the complete name. It is cetirizine hydrochloride or levocetirizine dihydrochloride. So that's the complete name of the drug. Okay, let's move forward. So this you can see this is hydroxyzine molecule in the from. Let me just remove this. Yeah. So this is the hydroxyzine molecule, and you can see the modification at the end. You remove the OH group, change it with the COOH group, or the you could say the acid component of that, and you attach itself to the 2 hydrochloride group, and this is how you get the structure of cetirizine as hydroxyzine compared to cetirizine. Okay. Now, these are some additional points regarding cetirizine. The sedation in one of the articles was found to be about 11% with 5 milligram dose and to 18% of patients with 10 milligram dose. Now, remember in the same article, they compared the level of sedation with placebo, and placebo was found to have 6% of sedation. Okay, so nearly double the amount, double the number of patients would be complaining of sedation with cetirizine as compared to placebo. That means sedation definitely happens with cetirizine. The amount is double to that of placebo, and since placebo is also causing sedation, that means there is some kind of psychological cause also there for present for sedation. Other side effects include fatigue, dry mouth, headache, nausea. See, what happens is that they are poorly lipophilic. Okay, second generation antihistamine are poorly lipophilic, but they are not completely lipophilic. So some amount will leak through the blood-brain barrier inside the brain environment, and will attach itself to the intracranial histamine receptors or intraneural histamine receptors, and will lead to some side effects. Similarly, some of the cetirizine will have some kind of attachment to H3 receptors, causing a release of acetylcholine, leading to cholinergic side effects. So these are all side effects which have been reported, but they are all manageable. So, in autonomic nervous system side effects, anorexia, flushing, increased salivation, increased urinary retention, all these side effects have been mentioned in the last video with first generation antihistamines. So, the level of anticholinergic side effects, or the level of cholinergic side effects, or the level of neural side effects will be seen with second generation also, but the intensity and the propensity and the probability will be reduced, a lot reduced as compared to first generation antihistamine. Cardiovascular side effects like cardiac failure, hypertension, palpitation, tachycardia. Be very careful in using patients who are prone to torsade de pointes, because arrhythmias have been reported, but they are very rare. This is like 1%, less than 1%, 0.2, 0.3%. So we just have to keep that in mind. And these are not at all contraindications, not in fact absolute contraindications. The interaction with thiophyllin has been reported in the product insert. Okay, so it has said that dosages of 400 milligram thiophyllin significantly increase the T half of cetirizine. T half of cetirizine. So these drugs not to be taken. Thiophyllin is used in patients with asthma. So remember that in asthma also people give a lot of combinations like Montelukast levocetirizine or Montelukast cetirizine, or in fact somebody, and most of the chemists are giving cetirizine. So make sure, get a good history if they were on theophylline or not. is pregnancy category B. Nearly all second generation antihistamines are pregnancy category B. It is found to be excreted in breast milk, so the usage in nursing mothers is not recommended. Remember, the age of usage is more than 6 months. This is by the time the weaning starts and lactation is kind of on the declining trend. But it's important that if a mother is nursing, it's better to avoid cetirizine. Maybe go for safer alternatives like hydroxyzine or chlorpheniramine. Okay. No abuse or addiction potential have been found. If a person overdoses on cetirizine, only symptomatic management, no dialysis. Why no dialysis? Because cetirizine cannot be removed by dialysis. It is the dialysis procedure is not able to extract cetirizine. So if you have a patient who has just recently overdosed on cetirizine, it's better to use activated charcoal to absorb the excess cetirizine in the stomach, or use a gastric lavage or induce vomiting only in the early stages. Do not induce vomiting in the late stages because it may lead to aspiration in an sedated patient and can cause aspiration pneumonia. So, vomiting induction is only in the earlier stages. Let's discuss the second drug here, levocetirizine. Now, levocetirizine is R enantiomer of cetirizine. Okay, you also have the S enantiomer, which is known as dextrocetirizine. Okay, dextrocetirizine. So dextro is right, levo is left. So you have levocetirizine, dextrocetirizine, and dextrocetirizine has no antihistamine action. No antihistamine action. So it's not used. We use levocetirizine. It is found to be more potent than Loratadine. The concentration is roughly about 5 milligram. You also have tablets available of 10 milligram. The syrup is 2.5 milligram for 5 ml, and you also have 5 milligram for 5 ml syrups available. It has been approved for usage more than 6 years of age. However, more than 2 years of age also in multiple patients is found to be safe. Okay, so these age restrictions are based on good controlled studies. Only after good controlled studies that a drug gets approval to be used in a certain age group. And when more than let's say patients in the age of 2 to 6 years, if there are no good control studies in that age group, the drug usually doesn't get approval to be used in that age group. Doesn't mean it's not safe. If you read a lot of articles in patients ranging from 2 to 6 years of age who have been given levocetirizine, the side effect profile has generally been favorable. Okay, so this is the molecule structure of levocetirizine. And that's all. We should not discuss molecular structure. Let's move forward. So in pharmacology, the half-life is about 11 hours. Some articles mention 8 to 9 hours. So remember that you can answer from 8 to 11 or 9 to 11 hours. That is okay. Peak levels is in 0.75 hours. Bioavailability is 77%. It has significant renal excretion. Significant renal excretion. Remember in cetirizine, it also had a good amount, around 70% renal excretion, and this is more than that significantly. So you need to reduce the doses or adjust the dosages in old age where kidney might not be functioning properly, or in patient with renal failure or dialysis. This is also pregnancy category B. In renal impairment, dose adjustment is required, as I've already mentioned. In patients who have creatinine clearance of less than 10 ml per minute, levocetirizine is not at all recommended. It's better to use other drugs, maybe like Bilastine or something. Okay. In patients with hepatic dysfunction, no dose reduction is required. So if your patient is having good working liver but not so good kidney, you can use levocetirizine. In children, you do not exceed the recommended dose of 2.5 milligram a day in children from 6 to 11 years of age. Why you don't do that? Because 2.5 milligram a day has significant effect. And when we say significant effect, it means significant clinical effect and significant side effects. Okay, so 2.5 milligram a day dose is enough to take care of everything in patients with age from 6 to 11. Okay, let's move forward. Sedation or sleepiness was found to be in 6% of patients. Nasopharyngitis was found to be in 4%, while cholinergic side effects like fatigue, dry mouth, pharyngitis seen in 4% each. One drug that that the product insert mentioned that it has interaction with ritonavir, which increases the half-life of levocetirizine. Okay, so levocetirizine half-life is increased with ritonavir. Ritonavir you would be using in patients with HIV or retroviral infection. So just a bit careful on that. Careful in geriatric population because you have to modify the doses as per the renal capabilities. Overdose is treated as same. It can present as agitation in children. That means children will be more hyperactive in cases of overdoses. It can present like that. So if a patient is reported to have who have taken a lot of levocetirizine but appears non-sedated, hyperactive, energetic, it might still be an effect of increased dose of levocetirizine. The management is symptomatic, no dialysis, just the same as cetirizine. Okay. So we have discussed two second generation antihistamines, cetirizine and levocetirizine. We'll be discussing the third drug today, Loratadine. Okay, so Loratadine is available in oral dosages of 10 milligram tablets or 5 milligram per 5 ml syrups. It is also available as rapidly disintegrating tablets. The trade name is Claritin Ready Tabs. So Claritin is the trade name of Loratadine and Claritin Ready Tabs is trade name of rapidly disintegrating tablets. So what do we mean by that? These are tablets which you can put on your tongue and it rapidly disintegrates on your tongue so that the onset of action is quicker. Okay. So Loratadine is a piperidine tricyclic antihistamine which is selective for peripheral histamine receptors. That means the action on CNS is not there. Okay. Peripheral histamine receptors. The active metabolite is desloratadine. The full form is descarboethoxyloratadine. So in the body, loratadine gets converted into desloratadine. The onset of action begins from 1 to 3 hours. We are talking about the normal loratadine, not the rapidly disintegrating one. Maximum effect is seen in 8 to 12 hours. So it's a better agent not to abort an urticarial reaction. It's a better agent to suppress the urticarial reaction or keep it suppressed. Okay, so it's a good idea as a suppressing agent or a maintenance agent. It is recommended for use in patients more than 2 years of age and it can be taken with food, but no alcohol is required. No alcohol is recommended. See, all the antihistamine has certain amount of sedative action. Alcohol, benzodiazepine, any other drug which causes sedation will only potentiate the adverse effects of cetirizine or any other antihistamine. So this goes without saying that alcohol is prohibited, or you could say it is not at all recommended when the patient is on antihistamine. It might lead to excessive sedation and it can lead to adverse outcomes. So alcohol, patients should be guarded against usage of alcohol while they are on antihistamines. So this is a structure of loratadine and you can see the tricyclic structure 1, 2, 3, a tricyclic structure of loratadine. So the half-life is about 8.4 hours, roughly the same as cetirizine. Although some books mention ranging from 2 to 14 hours, but 8.4 hours is a good enough answer in your vivas. Peak level occur from zero point 0.7 to 1.3 hours after intake. It undergoes significant hepatic metabolism. So it's a drug which undergoes degradation or metabolism by cytochrome P450 enzymes. So all the drugs which are inhibitors of cytochrome P450 will increase the levels of loratadine in the system, and all the drugs which increase the activity of cytochrome P450 will decrease the clinical effects of loratadine. So just have to keep in mind, although these kind of drug interaction with cytochrome drugs are not that clinically significant while giving antihistamine. So they may not be clinically significant, but it's a good idea to keep in mind, especially when a patient is receiving a lot of other a lot of other drugs. So there is a potential for drug interaction. It is excreted in through kidneys, that means through urine, and through hepatic excretion. About 80% of the drug is excreted by the liver, and it is unchanged. So most of the drugs goes unchanged out of system. That means very limited amount is converted into desloratadine, and the clinical effects happen. The pregnancy category is B, as usual. Now, Additional points about loratadine: it can affect potassium channels. So effect of potassium channel means it can have propensity of cardiotoxicity or muscle related side effects. So this can happen with loratadine, so keep that in mind. This effect on potassium channels was not found to be clinically significant. So they do affect potassium channels, but it doesn't translate into any kind of clinical presentation. Okay. Antifungus do not alter clinical and safety profile. Remember that I said that cytochrome P450 is required for metabolism, and there are many drugs which interact with cytochrome P450 enzymes. One of the most famous is ketoconazole. So whenever you're using the azole group of drugs, you should keep in mind potential drug-to-drug interaction. But in clinical scenario, that drug-to-drug interaction is not that seen. The safety profile is also not altered. Doses should be changed in patients with liver and kidney impairment. Remember that loratadine has significant liver metabolism and a major excretory route is urine. So if any of these are impaired, you should consider changing the doses or decreasing the dosage to a lower amount. Loratadine is heat and light sensitive. If you remove loratadine from the blister packs, you have to consume it as soon as possible. It might degrade with exposure to light and heat. In case of overdose, it is managed similarly as other antihistamine, only symptomatic management and gastric lavage or activated charcoal. Okay. Now the fourth drug that we'll be discussing is the active metabolite of loratadine, desloratadine. So desloratadine is available in 2.5 milligram for 5 ml oral syrups or 5 milligram tablets, or also rapidly disintegrating, and here it is known as Clarinex ready tabs. So Clarinex is the trade name of desloratadine, and Clarinex ready tabs is rapidly disintegrating. Okay. So again, like loratadine, it is piperidine tricyclic antihistamine selective for peripheral histamine receptor. This is same as loratadine. It has been found to be around 5 times more potent than loratadine. So the potency is increased by 5 times the potency of loratadine. It has little or no anticholinergic activity, causes minimal sedation, and has no cardiotoxicity. Okay, and desloratadine lately has become one of my favorite antihistamines to use. I use it regularly and a lot. Okay, and the potency has around 5 times of that of loratadine. That means single dose is enough. And I usually start with twice a day doses and then taper quickly to single day dose. Okay, now this anticholinergic activity or minimal sedation or no cardiac toxicity have been found to be same at 9 times the usual doses. So even if you increase the doses to 9 times the usual doses, these kind of side effects are still not seen with desloratadine. So it becomes one of the safest antihistamine. Okay, it can be taken with food. No alcohol is recommended. The age of usage is more than 2 years of age. Okay. So this is the tricyclic structure of desloratadine, and this is the tricyclic structure of loratadine. So this is loratadine, this is desloratadine, and you can see that the C2H5O group is being exchanged for a H group here. Not in fact this group, this whole group is exchanged for a hydrogen atom. So this kind of structure is changed, and remember that loratadine gets converted to desloratadine in the system. So one additional information, desloratadine gets converted into 3-hydroxy desloratadine in the system, and both desloratadine and 3-hydroxy desloratadine are both antihistamine. They both have antihistaminic action, and the pharmacokinetics and pharmacodynamics of 3-hydroxy desloratadine is same as desloratadine. So this is just an additional information. You need not be worried by that. The half-life is 27 hours, which is very long. It is nearly 3 times of loratadine half-life. Okay, so it is one of those drugs which has the highest half-lives in second generation antihistamine. Remember, in the first generation antihistamine, the highest half-life was with chlorpheniramine. Okay, if I remember correctly, it was around 11 or something, 12 hours. I don't remember that much, but 27 hours is the highest highest half-life in second generation antihistamine. Peak level occurs in zero point 0.7 to 1.3 hours. It is metabolized by SAP enzyme, but these are not significant. In Loratadine, it was significant, but in Desloratadine, it is not that significant. Okay, again, around 80% of drug is unchanged, but it undergoes minimal renal excretion. So remember that in Loratadine, it had significant renal excretion. So you had to decrease the doses or change the doses while using in patients with kidney impairment. But Desloratadine doesn't have that much amount of renal excretion. So it is considered safe in renal impaired patients. One change is that pregnancy category C has been given to Desloratadine. Remember, in Loratadine, the pregnancy category was C. Sorry, in pregnancy category was B, and pregnancy category B is the category which is shared by a lot of antihistamine. One of the exception is Desloratadine, which has pregnancy category C. Okay, the other being Fexofenadine, but we'll discuss when we'll come to Fexofenadine. The anti-wheel effect occurs in 1 hour. Now, what is anti-wheel effect? So, a good way of checking the efficacy of antihistamine is to inject histamine intradermally, and then a patient takes the drug, and we'll see when the wheel formation or the wheel goes away. Okay, that is known as the anti-wheel effect. So, in Desloratadine, the wheel goes away in 1 hour. So, it is known as anti-wheel effect. However, multiple studies have pointed out that this kind of anti-wheel test is not that good test to look at the efficacy, because it takes some time for the wheel to settle down, while the antihistamine or the histamine blocking effect has already started. So it's just one mention. Pharyngitis is seen in 4% of patients, dry mouth 3%, somnolence 2%. So the sedation is significantly reduced by 4 to 6% in Loratadine to 2% in Desloratadine. It is also heat and light sensitive, same as Loratadine, and overdose is treated similarly as we treat for any other antihistamine. Let's move forward. So now we'll discuss the fifth drug in our series, which is Fexofenadine. So till now, we have discussed Cetirizine, we have discussed Levocetirizine, then we have discussed Loratadine, and now we have discussed Desloratadine, and now we are coming to the fifth drug, Fexofenadine. So it's available in 60 milligram, 120 milligram, 180 milligram tablets or 30 milligram per 5 ml syrup. This is an active metabolite of a drug known as terfenadine. So fexofenadine is an active metabolite of terfenadine. So what happened was terfenadine caused a lot of cardiac toxicity. So because of that, the terfenadine was taken out of the market, and what used to happen was terfenadine was a product, it got converted into fexofenadine in the body, and fexofenadine had minimal cardiac issues. So we decided that we'll take out terfenadine and we'll use directly fexofenadine to negate the cardiac toxicity of terfenadine. Okay, just additional point, Astemizole is also an antihistamine which had significant cardiotoxicity. And because of cardiotoxicity, terfenadine and astemizole is not used now. Okay, so we have migrated to fexofenadine. Fexofenadine does not undergo liver metabolism. Okay, effect begins from 1 to 3 hours, maximum effect in 8 to 12 hours. It is recommended to be used in patients more than 2 years of age, can be taken with food, no alcohol recommended. And fexofenadine, or as it is famous by the trade name of Allegra, is one of the most common antihistamine that people start with, the other doctors start with. So multiple times you will see your patients already taking Allegra. Even patients know that Allegra is an anti-itch or anti-allergy medication. So they will come to you when they have already taken Allegra and fexofenadine. Okay. So that is the only issue with fexofenadine that I have is that the tablet size is too big. Okay, it's roughly this size tablet, and it's a very big tablet. On the other hand, cetirizine, levocetirizine, bilastine, desloratadine, hydroxyzine, these are very small tablets, easier to swallow. Okay, that's the only issue I have with fexofenadine. This is the structure of fexofenadine, and like the tablet size, the molecular structure is also very long. Okay, so just to show you the chemical structure of fexofenadine. The half-life is about 11 to 15 hours, or you could say, I think Wolverton mentions 14.4 hours, but articles mention 11 to 15 hours. Peak levels occur in 1 to 3 hours, but the effect lasts about 12 hours. Bioavailability is 85%. Excretion is predominantly through feces. Around 80% is excreted through feces, while 12% is excreted through the urine. It is also pregnancy category C, which it shares with Desloratadine. Okay, so two second generation antihistamine, Desloratadine and Fexofenadine, have pregnancy category C, while the all others have pregnancy category B. Now coming to the last drug of second generation antihistamine, Bilastine. Bilastine is one of the newer antihistamine. It has, I remember around 4-5 years or 6 years back, it was launched with much pump and show, and a lot of doctors, a lot of people started migrating towards Bilastine. But technically, the advantage of Bilastine is that it has found to have minimal drug-to-drug interaction, and the safety profile in elderly patient was significant, not significantly, but much better than other antihistamine. So whenever I have to treat patients who are old or taking multiple drugs, I do use Bilastine. But remember, before Bilastine was available, we were still treating old patients. Okay, so that is the only advantage that I see with Bilastine is minimal drug-to-drug interaction, minimal dose changes in liver and kidney impairment, and a good safety profile in elderly patients. So Bilastine is available. Where is my cursor? Yeah. So Bilastine is available in 10 milligram tablets and 20 milligram tablets. There's also a 40 milligram tablet available, but that's not usually available in the market. Okay. So Bilastine 40 is there. Its combination with Montelukast is also come out now. So 10 milligram, 20 milligram, and a syrup form of 12.5 to 5 ml. 12.5 milligram per 5 ml syrup formulation has also been present. The action begins within 1 hour of intake and it lasts for about 26 hours. Now, it has been approved in treatment of allergic rhinitis in patients more than 12 years of age. Now, the approval has been more than, okay, just a second. Yeah. So for rhinitis, the approval for Bilastine is only after 12 years of age. Okay, while for urticaria, the approval is for more than 18 years of age. So like I told you, like I've said it to you, that whenever I'm treating older patients, I do migrate towards Bilastine, but it has only been approved for usage in patients of more than 18 years of age. So it can be taken with food. The product insert mentioned that Bilastine is better absorbed when taken empty stomach, but the clinical efficacy doesn't change much. So it's better to ask the patient to take it timely rather than with meals or without meals. It's better that the timing is maintained. Okay, so that's for Bilastine. This is the structure. It looks like a very complicated structure for Bilastine. So just to show you the structure of Bilastine. Half-life for Bilastine is about 14.5 hours. Peak levels occur in 1 hour. Bioavailability is 61%. It undergoes minimal hepatic metabolism. Okay, minimal hepatic metabolism. The excretion is through the feces, or while the liver, around 66.5% of the drug is removed by feces, while the remaining 28.3%, you could say the second major chunk, is removed by urine, and the drug is unchanged. It is not, degraded to its metabolite. The unchanged drug is removed, while the remaining sample is what actually leads to its antihistaminic side effect. The pregnancy category for Bilastine is B for Bilastine, B for pregnancy category, although the data is less. For its efficacy, its safety in lactating mothers has not been studied very diligently, but like all antihistamines, we believe that it does get secreted into the milk. And remember, that it has not been approved for usage in less than 12 years of age. So during lactation, the drug might get passed on to infants, causing side effects and adverse effects. So you should be careful while giving it to a female patient who might be lactating. It's better that you can opt for other antihistamine which are much safer in lactation. Or if required, you can go for first generation antihistamine. Sedation has been reported in 4% of patients, which is roughly equal to the other patients. So it is not that that Bilastine has better side effect profile as compared to other antihistamine, but in studies involving older patients, it is found to be less reactive to or less interactive to other drugs which they might be taking. Remember, older patients would be on antidiabetics or antihypertensive drugs or and cholesterol lowering drugs. So when they're taking a lot of medications, it's better to use an antihistamine which has minimal interaction. Okay. Other side effects like anemia have been reported, but they are very rare. Now, why does antihistamine cause anemia? Histamine has some action on erythropoiesis or formation of new red blood cells. So when you block that action using antihistamine, you get anemia. Okay, so that kind of side effect is reported. Okay, no dose changes in old age. Okay, so you don't have to much titrate it as you have to do with other drugs. Not much dose changes are required. But in the product insert, there has been a warning of QTC prolongation. So if your patient is prone to arrhythmias, it's better to use other drugs like Desloratadine, which has minimal or no cardiotoxicity in your patients. Okay, Bilastine has found to cause QTC prolongation, but remember, in all antihistamine, all the side effects have been studied in doses much higher than the doses that we use. Okay, but as a warning for arrhythmia, it has been mentioned in the product insert that QTC prolongation does happen with Bilastine. One more thing that has been mentioned is that grapefruit juice decreases bioavailability by 30%. Where's my pen? Yeah, grapefruit juice decreases bioavailability by 30%. So I don't know while how are we going to get access to grapefruit juice. But if your patient is drinking grapefruit juice, and I think there is one more juice, bitter orange juice. I don't know what that is. Okay, so bitter orange juice. So even that has found to decrease the bioavailability of Bilastine. Okay, so grapefruit juice and bitter orange juice decreases bioavailability of Bilastine by 30%. And remember that Bilastine has good absorption, good bioavailability when taken empty stomach. But even if the patient takes it with food, not a problem. It's better to take it empty stomach, but not manipulate or not miss a dose. Okay. Now, with this segment, we have discussed second generation antihistamine, each individual drug in significant detail. I have focused more on the salient features of each and every drug which differs them from other drugs of the same class, so that I've tried to be a bit less repetitive for these kind of drugs. Remember that there is a considerable overlap regarding mechanism of action, excretion, metabolism, side effect profile of these drugs. They can be used much more interchangeably. Only few additional points must be remembered for each drug. So in this video, the video on second generation antihistamine, I focus more on those differing aspects of those drugs. If you go back and see the first generation antihistamine video, we have discussed more about the normal action of histamine and the normal action of antihistamine. And this video is discussing only the changes that these drugs have as compared to first generation antihistamine. Now, from this part of the PPT, we'll be discussing the clinical efficacy, the additional points for second generation antihistamine as a whole. Remember that clinical efficacy has been found to be same with all the drugs. They have nearly the same clinical efficacy. Adverse effects are also same and shared by a lot of antihistamines, second generation, and it has been found to be more or less same to placebo. Although in the previous studies we have seen that it can be as high as double the amount in placebo, but the sheer magnitude is found to be not that significant. We just have to keep in mind that these kind of side effects can occur with these medications. Adverse effects increase when using in the age group of 2 to 6 months. So remember, the antihistamines are not that much approved to be used in young age. All of the antihistamines are roughly approved after the age of 6 years. If you use it between 2 to 6 years or 2 to 11 years, use a very low dose, because a low dose is sufficient to cause the clinical effects. If you're using in patients in less than 6 months, the adverse effect profile is significantly increased. So you have to be very, very, very careful while using in that age group. It's better to use first generation antihistamine in that cases. Renal dose adjustment is a good idea. So in most of the antihistamines, you have renal excretion. So it's better to use a lower dose in patients with impaired kidneys. Okay. Minimal relation with food intake. So we have studied that some of the antihistamine can have some relation with food intake, but the clinical efficacy is not that much damaged. So it has minimal relation with food intake. It's better to counsel your patients to take those medication with time. So what I usually do is, let's say if I have a BD dose, so I tell them to take it at 8 a.m. and 8 p.m. Okay, and if they ask that should I take it with breakfast or dinner, it's better to counsel them using time: 8 a.m., 8 p.m., 8 a.m., 2 p.m., 8 p.m., something like that, so that the timing is maintained, so that you have a proper blood levels of antihistamine. Do not combine them necessarily with the food intake. Now, fexofenadine and bilastine are substrate for P-glycoprotein. What do we mean by that? So P-glycoprotein are somewhat like an efflux pumps. So what do we mean by efflux pumps? You have a cell, okay, and then you have a P-glycoprotein pump. And when we say efflux, means it is responsible for taking the drug outside of the cell. Okay, this is known as efflux pumps. What P-glycoprotein efflux pumps does is it removes the drug, or removes the particle, removes the chemical out of the cell. And when we say that fexofenadine and bilastine are substrate for P-glycoprotein, what we mean by that it is significantly removed out of the environment quickly. And the blood-brain barrier has significant amount of P-glycoproteins. So any drug which might have accidentally or even minimally crossed the blood-brain barrier, it can be easily removed by P-glycoprotein. So fexofenadine and bilastine can be easily removed, and that is why you have minimal sedation, minimal CNS effect with fexofenadine and bilastine. Okay, so because they get very easily removed, even if some of them manage to cross through the blood-brain barrier. Sedation and sleepiness can have a psychological component also. As I told you that placebo can report as high as 6% of patients having sedation. So there is a psychological component. Many times I have felt that I've given an antihistamine to a patient and they're perfectly fine by it. And after 1 month, when they Google about it, they find out that, that it is sedative, and they start complaining of sedation. So that also happens. It can have a significant psychological component also. Just keep in mind that occupation and working times have to be noted. That means if a patient is engaging in an occupation that requires him to use heavy machinery or driving or anything, anywhere where alertness is required, you have to counsel them that these drugs can have some kind of sedative possibilities. It's better to take them at bedtime. And what I usually say is 1 hour before bedtime, so that by the time the onset starts, the patient starts to feel sleepy and they sleep. Many times your patient will complain of increased sleepiness in daytime, and that is because the drug is persisting in the system when the patient wakes up. So it's better to take the drug around 2 hours before bedtime. So by the time the patient wakes up, most of the drug is excreted out of the system. Okay. Uh, Histamine is a G protein coupled receptor. We have already discussed in the first slide of this video that it's a G protein coupled receptor. H1 antihistamine can have anti-inflammatory effects. Now, histamine does not only control itching and pruritus. It also, as we have seen, that cetirizine controls eosinophil migration. Okay, eosinophil migration. There have been multiple studies which show that histamine is one of the mediators that leads to secretion of inflammatory cytokines. So when you use antihistamine, this action is also stopped, and it can act as a very subtle anti-inflammatory drug. So H1 antihistamine can have anti-inflammatory properties. There are other mediators at play. Remember that itching is not only controlled by histamine, you have other mediators, acetylcholine, substance P, somatostatin, vasoactive peptides, all those, there are at least 10 to 15 other mediators of itch also. So if your patient is not responding to antihistamine, could be possible that in that particular disease they have other mediators acting. For example, a debate goes on that whether we should give antihistamine in atopic dermatitis because histamine is not the only mediator of itching. And that is why you should consider other antipruritic agents, other drugs like doxepin, or maybe nerve suppressants like neural suppressants like pregabalin or gabapentin. So these kind of drugs are routinely used in atopic dermatitis. I use it in intractable itching. Okay, so I have not discussed newer drugs like Loratadine and Ibastine. These are not newer drugs, but these are drugs which we don't usually use that much as compared to other drugs like Levocetirizine or Desloratadine or Bilastine or Fexofenadine. So I've decided to omit Loratadine or Ibastine. If you want to learn anything about those drugs, just download their product insert and go through it. Okay, so I will not write anything on this slide. You can take a screenshot. This is just a summary of various antihistamine, their adult dosage roughly, and the pediatric dosage. This is just for knowledge. Remember, this video is not for the general public. Please do not see this video and go taking medication on your own. It's better to consult a doctor. We have a lot of side effects profile with these safer drugs also, so to say safer drugs. It's better to find the cause of a disease and act on that rather than just managing the symptoms of it. Okay, so let's move forward. Now this table is somewhat important. I made this table so that we kind of summarize the second generation antihistamine. So again, I will not write anything on this slide for at least 5 to 10 seconds, so that if anybody wants to take a screenshot of this slide, you can take a screenshot. So in this table, I've tried to summarize the important aspects of all the second generation antihistamine. Okay, so where's my cursor? Yeah. Okay, so I hope you have taken a screenshot. So here in this column, I've mentioned the pregnancy category. So you can see that nearly all second generation antihistamine have B except Fexofenadine and Desloratadine. Okay, these two have C. The significant liver metabolism occurs for cetirizine, levocetirizine, and loratadine. The excretion is mainly by urine in cetirizine, levocetirizine, and mainly by liver in fexofenadine, or liver by liver I mean feces. That means through the bile as urobilin. As Foco. I don't remember what is this. What is the bile in feces? I'm not remembering. I'll just mention. Okay. So majorly the excretion through urine is seen in cetirizine and levocetirizine, and in fexofenadine and bilastine it's majorly through bile, and in loratadine and desloratadine the excretion is through both urine and feces. 40% roughly in through feces, 40% roughly through urine in both loratadine and desloratadine. Dose adjustment is required in patient with hepatic malfunction for cetirizine, loratadine, and desloratadine. While patient with not good functioning kidneys, you need to lower the dose of levocetirizine and fexofenadine. Okay, so this table kind of summarizes what clinically you should look at. Some additional remarks is that cetirizine is the safest second generation, levocetirizine is most potent, fexofenadine has highest concentration in skin. Okay, just one interesting aspect is that fexofenadine has around, if I remember correctly, plasma protein binding of about 70-75%. That means the 1/4 drug is free in the system. Okay, the highest concentration is achieved in skin by fexofenadine. Loratadine undergoes maximum liver metabolism. That's why you have to change the dose in liver failures or liver damage. Desloratadine has minimal to no cardiac issues, and Bilastine and has minimal interaction with drug-to-drug interactions. Clear? So these are some remarks about individual antihistamine. Okay, and in the age group, just all of the antihistamine, the second generation antihistamine, have been approved for the usage in more than 2 years of age, except three: levocetirizine more than 6 years, Fexofenadine more than 6 years, and Bilastine more than 18 years. So just to remember, all second generation antihistamine more than 2 years except Levocetirizine more than 6 years, Fexofenadine more than 6 years, and Bilastine more than 18 years for Urticaria, more than 12 years for allergic rhinitis. I think this is the last slide of the presentation, and I'll just close this presentation with some recommendations for reading. I will copy paste this URL in the description. Just take it from there, go and access the full article and go through it. These are very good articles like newer generation antihistamine and risk of adverse events in children. In the first part of the video on first generation antihistamine, I included the article on elderly patients. So just read through these articles and you will be much assured about the safety profile of antihistamine. Second generation antihistamine and update. Updosing of non-sedating antihistamine. Now, updosing has been a very good debate. Should you use higher dose of antihistamine or higher frequency of antihistamine? So that kind of discussion is there. Should you change the class of antihistamine or should you continue with the same class but higher doses? That is kind of very subjective, but I hope after looking at these two videos, you can easily titrate antihistamine, whether to use double the dose or spread it out over the day. So what I use is that if single dose leads to 50% reduction in disease activity, I double the doses till the side effects become troublesome. If it leads to 100% reduction but the effect lasts only for few hours, 6 hours, 8 hours, I do a twice daily split but the dose remains normal. So this is what I use normally. This is what everybody uses, I think. But I hope after these two videos you are now much surer about using antihistamine. Before that we were using antihistamine because in my opinion these are one of the safest drugs, but now we can titrate it and give in specific population like patients on dialysis or older patients or children. We can now give specifically to those drugs. Now I would highly recommend you to read product inserts of individual drugs. Okay, product inserts of individual drugs. You want to know anything important about the drug, you read the product insert. It's freely available, it's without any cost, it's available on the internet. Just write drug XYZ product insert and you will get a PDF. Go through it, you will learn a lot about those drugs. Okay, with that the video on second generation antihistamine is finished. Please go back and see the first part, the video on the first generation antihistamine, and then you come back and see the second generation antihistamine, and with only these two videos your concepts about antihistamine will be clearer. You will know when to use, how to use it, and you can easily titrate the doses of antihistamine as per your liking, depending on the clinical effects that you desire. And without further ado, it's already been long, we have just crossed the 1 hour mark. So with that, adios, bye bye, enjoy your weekend, and we'll meet again next week with a different video. I don't know what video I'll make, but maybe we'll have something interesting and something different as compared to what we have been doing previously, but we'll be again discussing something related to dermatology. Till then, bye bye, enjoy your weekend, good night.